Hi y'all, and welcome back to Professor Truelove's Concepts for Nurses series, and I am Professor Terry Truelove. In this episode, one of the respiratory concepts, we're going to look at our first in a series that reviews obstructive lung disease. In this case, we'll look at asthma, assessments and interventions. Sources for this episode include Iggy's Medical Surgical Nursing and Sol's Introduction to Critical Care Nursing. Asthma is a chronic disease in which reversible airway obstruction occurs intermittently, reducing airflow. Airway obstruction occurs by both inflammatory and airway tissue sensitivity, that is known as hyperresponsiveness, with bronchoconstriction. The inflammation obstructs the airway lumens, or the inside the tubes. This obstruction can be so severe that it can be fatal. In fact, at least 3,600 deaths from acute asthma occur in the United States every year, according to the CDC in 2015. An estimated 20 million, that is 8.4% of all Americans, are affected, and it may affect up to 300 million people worldwide. It tends to be more common in adult women than in adult men. It is slightly more prevalent among African Americans than in Caucasians, and the number of people with asthma continues to grow every year. The hallmark of asthma is the reversible and intermittent airflow obstruction that affects only the airways. It does not affect the alveoli. And this airway obstruction is caused by both inflammation and airway hyperresponsiveness. And when we talk about airway hyperresponsiveness, we're talking about smooth muscle spasm that constricts the airways. So not only do you have inflammation, you have a more narrow airway. Add mucus, and you have obstruction of that airway. And this image highlights some of those changes. Not only the inflamed airway itself, but the bronchial constriction that occurs because of the hyperresponsive airways. Asthma can be triggered by many different things. Sometimes it occurs in the presence of specific allergens or general irritants such as cold air, dry air, fine airborne particles like smoke, microorganisms, and even aspirin and other NSAIDs. Increased airway sensitivity can occur with exercise or upper respiratory illness, or even for reasons that we don't know. During assessment, it is important to ascertain the patient's history because asthma, again, is intermittent and reversible. So they may reveal a pattern of dyspnea and difficulty breathing that would indicate that they indeed have asthma. Their history may also indicate what triggers the asthma. So some clinical manifestations from your physical assessment include an audible wheeze and an increased respiratory rate, increased cough, the use of accessory muscles, particularly if in more advanced cases of asthma, a barrel chest from air trapping from a person who's been suffering from asthma for a long time, a longer exhalation breathing cycle, signs of cyanosis, and even signs of hypoxemia. An important laboratory diagnostic are arterial blood gases, and this is because arterial oxygen levels may decrease in acute asthma attacks, while arterial carbon dioxide levels may decrease early in the attack when the patient is breathing more rapidly, but increase later when gas exchange begins to deteriorate. Allergic asthma will have elevated serum eosinophil count and elevated immunoglobulin E levels, and the sputum will have eosinophils, mucus plugs with shed epithelial cells. Asthma affects the middle airways but not the alveoli. So therefore, you can ascertain how much these airways have been affected by using pulmonary function testing. This essentially measures how much, that is the capacity of your lungs, and how quickly air can move in and out. We do this by using forced vital capacity, which is the maximum amount of air that can be breathed out as quickly as possible. We measure the amount and the amount of time that takes. We also look at the very first second of that forced exhaled volume. If that is reduced, that will indicate a reduced airway size or bronchoconstriction. And we're also going to look at the peak expiratory flow rate. Again, that is affected by the size of the airway. If the airway is constricted, the PEFR will be decreased. Intervention for asthma must include the fact that it can be potentially fatal. So there is emergency management, including drug therapy. Once that crisis had been reached, it's important that we teach about self-management. Self-management includes not only lifestyle changes, but medication therapy plans, when and how these medications are going to be self-administered, and other things about self-management. Are there recognizable triggers, and are there non-pharmacological interventions that will help the patient to cope during the asthma attack? Drug therapy can be divided into emergency and maintenance types of therapy. Maintenance therapy is based on the step category, and it's based on the severity and how the patient responds to that treatment. There is preventative therapy by using controller drugs. These change the airway's responsiveness to prevent asthma attacks, and they should be used every day regardless of symptoms or symptomology. Rescue drugs actually stop the attack once it has started, which preventative drugs do not. So rescue drugs are usually medications that mimic the sympathetic nervous system and therefore provide for rapid airway dilation. There are both short and long-acting bronchodilators that are available. Your short-acting beta-2 agonists are generally your rescue medications. Long-acting beta-2 agonists cause bronchodilation through relaxing the bronchial smooth muscle. The onset of action is slow, but it has a long duration. Therefore, it is primarily used in prevention of an asthma attack and not in response to an asthma attack. Cholinergic antagonists work by inhibiting the parasympathetic nervous system, which causes bronchodilation. And methylxanthines are an older type of medications like theophylline. However, they are here because many plants, including yerba buena, have high concentrations, or I should say relatively high concentrations of methylxanthines, and therefore can be used as a home or folk remedy. Anti-inflammatory agents include corticosteroids, which disrupt the production pathways of inflammatory mediators, again, to reduce the amount of inflammation. NSAIDs have an anti-inflammatory property, and leukotriene modifiers block the leukotriene receptor, which prevents the inflammatory mediator from stimulating inflammation. These medications are available via multiple routes, including oral and inhalation, and the inhalation can be done by handheld nebulizer or metered dose inhaler. Normally, your medication used for rescue are via the inhalation route. Other treatments for asthma include exercise and activity to promote ventilation and perfusion, and, if needed, oxygen therapy via nasocannula or mask, particularly in the time of an acute asthma attack. A type of severe, life-threatening acute episode of asthma is known as status asthmaticus. This is an episode of airway obstruction that intensifies once it begins and does not respond to the usual type of therapy. This means the patient can develop such complications as pneumothorax or respiratory and cardiac arrest. The patient arrives in the emergency department with extremely labored breathing and wheezing. There you will note the use of accessory muscles for breathing, and even the distension of neck veins can be observed. Treatment is IV fluids, potent systemic bronchodilation, steroids, including things like epinephrine, oxygen, and your patient may require intubation and ventilation. Once stabilized, the patient can be extubated and, for the most part, can return to their normal life. The patient who suffers from status asthmaticus will not always suffer from status asthmaticus. Their subsequent attacks may be more mild, that is, a more generalized asthma attack. That does conclude another episode, but stand by. We are not done with obstructive lung disease. And that means we'll be talking a little bit more in our next episode. As always, I hope you learned a little bit. I hope you plan on listening again, and if you are, we'll see you then. Take care now.